welcome everyone. So I'm Ellie Harwich, Director at New Market Strategy, which is a health and life sciences consultancy. I'm delighted to be here today to be discussing a data-enabled health and care system. So there has actually this year been quite a lot of publications in this space, so ranging from the £200 million investment in safe data environments, the announcement of the tender for the federated data platform, the Ben Goldacre review, and I'm delighted to have Jess, who will be able to talk a bit more about the review as a co-author of it, the data strategy, and the list goes on, and it's probably about 12 different documents, announcements, and policy documents within the health data space. So needless to say that a lot has been happening, and I'm really delighted to be joined by three fantastic panelists to discuss this topic today. So we will have a 30 to 35-minute discussion, and we will keep about 10 to 15 minutes at the end for questions from the audience. And I will now ask, if possible, for the panelists to introduce themselves and also answer the question of what a data-enabled health and care system means to them. So Dan, I see you have the mic, so if I could start with you.
Thank you. Thank you, Ellie. Nice to meet everyone. Pleasure to be here today. So I'm Dan Onions. I lead the data management solutions for Quantexa. So Quantexa is an organization that joins together data, makes more meaning from it for decisions. For me, what it means to have a data-enabled healthcare system is really that those that are consumers of data really get the data that they need to be able to make a difference to patients. Whether that be the clinicians that are working directly with patients, whether that be the researchers that kind of need a complete view of those kind of patients in order to kind of make the connections and do the things they need to with the newer techniques around data analytics, deep learning, and those kind of things. And it's critical for healthcare that we achieve this within the NHS.
Great, thanks, Jess.
Hi everyone, I'm Jess. This is making me feel like I'm in trouble because I don't know why it's full naming me. Just Jess is fine. I'm the Director of Policy at the Oxford Bennett Institute. We are a research group inside the University of Oxford. We're headed up by Professor Ben Goldacre, hence Ellie referencing the fact that we wrote the Goldacre review. We also build big platforms and tools off health data sets, including Open Safely, which is England's largest secure electronic health records platform. For me, data-enabled healthcare, very similar to, I think, what Dan said. In clinical setting, it's right information, right person, right time. And then outside of clinical care setting, it's research, service analytics, and population health management.
Great, thank you very much. And Linda?
Thank you, Ellie. And thanks, everyone. It's great to be here. So I'm Linda Vernon. I am the Interim Digital Culture and Transformation Clinical Lead. So it's essentially a CCIO role, but we put the word culture in just to emphasize that it's not all about technology. And I oversee population health management and most of the sort of citizen-facing work that we do in Lancashire and South Cumbria Integrated Care Board. And yeah, for me, it's everything that that both of you have said already. It's about data being available at the right place at the right time. I think when we think of a system, I think it's about not just health data. So we're getting to a place where local government data is really helping to inform the way that we plan and deliver services. There's some really helpful data out not just from social care, but from things like assisted bin collections and people living in houses of multiple or single occupancy. And I think we need to start thinking much more holistically. And I think the other thing is that data is collected once but repurposed for whatever it's needed for, so that it's we're not capturing data in different silos and then having to try and make sense of it. But we capture it once, we reuse it, and we share that data as easily as possible.
Right. So we've been talking, obviously, about the power of data or the ability for us to have a data-enabled health and care system for quite some time. I don't know exactly to when we can date it back, but obviously it mentions that you see in the National Programme for IT, which was some 20 odd years ago. But yet we still struggle really to fully harness the value of the healthcare data that sits within the system. Do you feel that that's a fair assessment, that there's still quite a long way to go to meet the ambition? And if so, why have we struggled? And if I could start with you, Linda, and then go to Jess.
Okay, thanks, Ellie. So I started working as a physiotherapist 26 years ago, and I was writing in paper records, but I did learn how to use Excel. So I did start to capture some data in Excel and managed to sort of help people to understand how we were delivering services. So we've come an awfully long way since then. I think I alluded to it in my intro. I think data that is in silos hasn't helped, but I think we're getting much better at using information standards to try and help us to be able to aggregate data and like I said, to repurpose data and gather data from different places so that we can help to inform how we manage people. I think that I know the move towards more structured data I think is really, really helpful. We have the most utilised shared care record in the country in Langston, South Cumbria, and it's sort of accessed by clinicians way more often than the runner-ups behind us. But it's unstructured data. We're still not in that place of sharing structured data routinely. So we've a long way to go, and I know other parts of the country are further ahead in terms of sharing structured data for clinical care. I think one of the big challenges is around the process of data sharing. I think we're risk averse, and it's all about data protection, and I think we need to start to move towards a world where it's about enabling data sharing rather than thinking about protecting data. I think we need to sort of flip that and turn it into a more positive and make that process much more simple and more fluid.
If I actually could quickly ask just to follow, because I find that point really interesting, and given that you mentioned at the beginning that you had culture in the title of your job, how do you think that should be managed in terms of that change of culture and potentially greater appreciation as well of maybe the cost of not sharing information, as well as the risk to privacy to potentially sharing it? So how would you manage that?
So it's interesting because I've been talking a lot in the last few days about the difference between narrative and stories, okay, and how they influence us versus the influence of data and figures, the sort of quantitative versus qualitative stuff. And I think when you tell stories about the impact, the positive impacts of sharing data, I think it touches people's hearts and minds. I think that's where the culture change starts. And I do think there's something about the language we use and sort of turning that language and thinking more about enabling, empowering, putting the more positive spin on it, really. But I think we need to share good stories as often as possible.
Great, thank you. So Jess, back to the initial question, which is, do you feel that it's a fair assessment that things, that we've struggled to make progress, really harness the value of the data that sits within the health and care system, and your assessment as to why it is that we've struggled, if you agree with the premise?
So I think, if I remember correctly, the first time the NHS wrote an IT strategy for data was 1976. So
even longer.
It's older. There's a really good book that's like the GP infrastructure of the future, which is written in 1984.
Really, your bedtime reading.
Highly recommend. As you can tell, my favourite hobby is NHS IT policy archaeology. Yes and no. It's fair. It depends on where you're putting the ball, like where you're putting the benchmark. There has been progress. There's been huge progress. The issue is that it's ad hoc and a bit sporadic. And what has definitely been a struggle is achieving some form of overarching consistent vision. And hence you get repeated things. So if you do the archaeology thing, you will see them say the same thing again and again and again and again, almost on like a 3 to 5 year cycle, and it sort of never really hits the mark. There are a number of reasons for that, some of which Linda has just touched on. I think other reasons tend to be that there's a really, really big disconnect between the people at the top who make policy decisions and push down versus the on-the-ground reality. Clinicians, etc., are then also very busy, so they're not necessarily involved in the decision and user needs design, which means that there is sometimes a bit of a lack of willing to take things up. On the data sharing, data access issue, that is fundamentally because every time policy has tried to do that, whether we're looking at care.data or GPDPR or whatever, there has been no consistent commitment to technical framework that makes it possible to achieve privacy and broad access. Instead, it's just portrayed as this idea that it's a comms issue. If we tell people how much data is important, then they'll just be happy. So we need there to be more consistent investment in data infrastructure, and then that will help. But we should also be fair. Like, people have massive amounts of competing commitments. So yeah.
Yeah, of course. And Dan, obviously, Quantexa has worked in other sectors, particularly in banking, which are obviously sectors that have faced similar issues around legacy IT, kind of modernizing systems. So how has that sector dealt with it, and how do you think that the health and care system could potentially draw lessons on this?
Yeah, great question, Ellie. Yeah, banking, I mean, in many ways, there's very similar challenges. You expect a lot from your bank. You have to trust your bank a great deal. You want a great digital experience from it. But in reality, behind the scenes in a bank, there are thousands and thousands of separate systems, each with holding, siloed, fragmented data. And the banks have been struggling for a number of years and gone through numbers of iterations on how they bring that data together, whether that be things like data warehousing, operational data hubs, all these kind of technologies that they've been through. And they're getting to the point now where it is possible to kind of have data that you can bring together, that you can serve up for the needs of multiple different consumers in a secure way. And I think there's definitely kind of lessons that can be taken from the banking industry in particular, because of the those kind of need for transparency and trust. And there are differences, but there are also similarities. I mean, they need to take in very wide varieties of data. So, for instance, Linda was mentioning unstructured data as well. That's a big challenge within the banking space as well. Data that sits within these kind of very old systems that were initially captured in documents. These sources can be brought to bear. It's going to be a long journey, but it's definitely something that the lessons from those industries can apply to healthcare as well.
Great. And so one of the key aspects, obviously, that we've talked about, Jess, when you mentioned it's not sufficient to just tell the public, how using data and data for research can be great. It's not sufficient to just do that comms exercise. So obviously another key aspect of that is ultimately how you engage with patients and the public within that data conversation, and how do you make it in a way that goes beyond that, tokenistic patient on a panel that is kind of that tick box exercise of, yep, that's fine, I've engaged with the public, the patient. How do you move on from there and try to have kind of more meaningful engagement and discussions with, people whose data it is that clinicians and researchers ultimately want to use, or also companies to develop products? So have you seen any interesting initiatives in that space? Maybe I could go to you and then Linda.
Yeah, sure. So I think that's a really good question. I think there's a few layers to it. So first of all, start from a solid foundation where you are already explaining and providing a good levels of education, but also providing that, the actual information. We've ended up in this slightly strange scenario, I think, in the data space, where in almost every other aspect of healthcare, if we are doing clinical trials, for example, you spend an awful lot of time thinking about informed consent and what does this actually mean, whereas and what are you doing with me and with my body and all of that, whereas in data we tend to not have done that particularly well, tell people how their data will be protected, what technical frameworks will it be, etc. And you also get these very one-off hits, like, oh, I'll go and ask this particular community or that community, are you happy with using my data for X? Which is a completely contextualist conversation, and it's a one-off. And there's space for that, but it doesn't help you build an environment. So I think the better ways of dealing with it is to treat patients, publics, communities, citizens, whichever frame we're using in that particular context, as design partners in the whole process. So that means they've got to be embedded in whatever you are doing with the design from the very beginning. The engagement needs to be discursive, it needs to be iterative, it needs to be co-design focused, and it needs to be repeated, as opposed to let me just go and ask you a one-off question. Places that do it well, there are pockets of examples. The big issue, I think, and one of the things that we highlighted in the review, is that these are siloed examples of people doing it well. The quality of patient-public involvement and engagement across research space as well, I'm not just talking about policy, is really variable. And part of that is because we never teach people how to do it. We just sort of say, hey, go and I'm going to do this, rather than provide examples of best practice. So, yeah.
Great. Linda, would you have anything to add?
Yeah, and I agree with everything Jess just said, especially around transparency. I think we need to, transparency should be sort of considered the norm, really. I think user-centered design gives us an opportunity, if we embed that fully, I think it gives us a really good opportunity to ensure that patients and public are involved in all decision-making that, around not just data sharing, but digital as a whole. And it is time-consuming, and when we try to embed user-centered design in some of our digital transformation projects, there is an element of resistance and not fear, but fear of the resource implications, because it is resource intense, but it's the right thing to do. And I think if we can ensure that our patients are on board with us through the journey, like Jess just said, it shouldn't just be a one-off thing. We've done some work, but pre-pandemic, and I guess this is again reinforcing that it needs to be on an ongoing basis. We need to revisit, because people's perceptions change with things that evolve over time. And but we reached out and spoke to almost 2,500 people out of our population of 1.8 million. So and mostly the vulnerable, the people who are considered hard to reach, and we know they're not hard to reach. We asked them their perceptions on digital, how they might use digital, how they expected their data to be shared. From clinical experience, patients expect that data is being shared as needed for clinical care, and they don't realise sometimes that it's more challenging for data to be shared across primary and secondary care, etc. And I know that I think a really good piece of work was done as part of the Connected Health Cities programme a few years ago. Our local AHSN, the Northwest Innovation Agency, did some citizens' juries, and particularly looking at data sharing, and the sort of the overwhelming view was that people didn't mind their data being shared for the public good, particularly, rather than for themselves benefiting. So I think it's just about keeping those processes going and not doing them, as Jess said, as a one-off process.
Yeah. And obviously you kind of mentioned pre-pandemic, post-pandemic, things have changed quite a lot in terms of the NHS's relationship to the use of data. I remember there's this one blog that stuck quite a lot in my mind that was published by the transformation director at the time, NHSX, which was called The Power of Data in a Pandemic. And it was a blog published around about end of March 2020. And it's actually quite staggering to read that ultimately the NHS was going into pandemic preparation, writing a blog basically saying that, if you were to send Excel spreadsheets here and there, data would be, quite easily outdated. You wouldn't really have a clear version of the truth, and so on and so forth. So obviously things have drastically changed since then. There's kind of greater adoption, or at least acceptance of the importance of using platforms. How do you perceive the change in the relationship with the use of data, at least at a local level, and do you see any areas of potential that are the kind of lower hanging fruit that you think actually if we did this, this could be quite transformational? So if I could start with you, Linda, and then
and work back. So I mean, COPI was really, really helpful for us, and you know, enabled very rapid data to be shared across different sectors. We have historically have a good working relationship with our local councils, so we've been pre-pandemic we were already sharing local government data and health data, and we've had our district councils as well as upper tier councils contributing data to our shared care record and to population health management. I think one of the sort of massive insights was how quickly we were able to pull data together when we actually put our minds to it. So our one of our population health sort of BI tools developed a COVID dashboard within a few days, pulling together, you know, some of the national data sets with local data, and we were able to drill right down, and I could look at a map of, you know, where I live, and I knew that there were X amount of cases around me. It was, you know, it was so granular, and we wouldn't have thought to do something so granular. So I think it's really, it's enabled us to think more big, sort of like a bigger vision of what we can do in terms of population health management, and that pulling together and aggregating different data sets, and the relationships that were built as part of the resilience forums, you know, that as part of the COVID response, I think are long lasting now. I think it helped to broker some really strong relationships.
Yeah. Jess, could you tell us a little bit, obviously, about the work that has been done around open, safely, and the whole thinking around trusted research environments, which obviously appeared quite a lot in the Goldacre review, but also was taken up in the Data Saves Lives strategy and has shaped quite a lot of the policy at national level around safe data environments?
Yeah. So COVID sort of changed everything. Unfortunately, I think there's a slight revert back to type now that COVID is over, which is an interesting one, and it comes right back to the point around culture that we made at the beginning. There's something very interesting about the fact that because COVID was in your face as a health emergency, people went, oh, okay, let's go. But actually, we have multiple health emergencies happening in real time, and we could potentially apply that same logic. The fact that COPI was so helpful also, I think, demonstrates that information governance law is no longer fit for purpose and needs massively revising. You know, relying on law that made sense when 30 odd years ago is a problem. Trusted research environments, so very briefly, for anybody who doesn't know what a trusted research environment is, don't move the data, keep the data where it is, send your analytic code to the data so that you can analyze in real time and you don't infringe on privacy, which means you get over this dichotomy of privacy versus access, because you are never looking, nobody ever has eyes on the raw data, and you're not relying on it moving around the system in highly risky ways and slow ways. So we built Open Safely. Like I said, it's the largest EHR platform in the country. We built it in 40 days, which is simultaneously amazing and really annoying because it's not 42. And if it was 42, it'd be the answer to everything, and that would make me really happy. We have access to 58 million patients' full records. So unlike things like CPRD, HES, or SUS, or any of these extracts that you might be familiar with, it's not a cut of the data, it's the full record, which allowed us in those 40 days to produce it is still currently the biggest study on the factors associated with COVID hospitalization and death, and it's since produced more than 30 different academic papers. We have 125 COVID research projects running in it. But I think more than anything, it demonstrated that if you have a technical platform that does protect privacy from a privacy preservation by design perspective, you do build trust. There was a citizens' jury that was done about a year ago. We came up with 100% trust from patients and the public. And what that has done is demonstrate to the system that actually platforms allow you to sort of have your cake and eat it too, if you are designing well, and hence we wrote about it in the Goldacre Review, and it has since become sort of national policy that TREs, renamed SDEs, secure data environments as opposed to trusted research environments, primarily because trusted is a loaded term and not only research happens in these environments, so does service analytics, etc., has become the national working policy because it allows people to realize, yes, we can have broad access whilst also maintaining privacy.
Great, thank you. And so, Dan, where do you feel that companies like yours can actually add the most value in healthcare, kind of building on these trusted research environments?
Yeah, great question, Ellie. I think one of the kind of key challenges as we move, especially in a world of like ICSs and the need to kind of get a more complete view of like a patient record, and Jess mentioned, for instance, Linda mentioned the kind of local council data, things like that. If you can get a much more a more longitudinal view of the patient, essentially join those data sources up, I think that's critical to kind of the success of researchers and research environments for clinicians, things like that. What we're very good at as an organisation, Contextra, is joining up data sources, even when there's no direct keys between those sources, even when there's kind of quality issues, and really trying to overcome that kind of fear that data quality is going to affect the outcome because you can join the data up. Once you then see that data together, you can then go about, fixing those diverse quality issues across the data. You can start joining up and creating a context around a patient, understanding the real patient pathways. And then, when we kind of, what we really want to get onto, of course, is using things like analytics, machine learning, AI, to really, better the lives of patients, really. And, you need kind of a complete view of a patient to do that. And that's critical. So that kind of data hygiene, that data joining is really important within that journey, so that we can start giving indicators to people doing policy, people doing coordination at the ICS level, people doing research of the kind of the risks and the opportunities within that data. And I think really only at the beginning of that journey, really, and we're really excited to be a part of that.
Great. So final question before we open it up to the floor. So there has been an announcement of £200 million of funding, right, for the Data for R&D program, and more recently the publication of the Secure Data Environment for the NHS Health and Social Care data, which basically states that safe data environments is going to be the main way in which you can access data in the NHS. So in a minute or less, what are your hopes and fears for this program? If I could start with you, Dan, and a minute or less, just a couple of words.
Okay. I mean, my hopes are that the trust can be retained by the patients, because it's essentially patients' data that we're talking about. My hopes are that the innovation can be injected into the system, that we can really get the kind of the fruits of it. My fears are that it will maybe not go as fast as we would want it to achieve those goals, I think, really.
Great. Jess, hopes and fears?
So hopes is that this provides the platform for truly unlocking the potential that we have spoken about a lot, because SDEs are not just about privacy, they're also about standardizing the ways in which you work with the data, so modern open computational working methods, data curation, all of these things which we currently do in a slightly ad hoc way, and it acts as a massive barrier to good use of data. My fears are that it would be operationalized poorly, so we need to be careful of what we call trinos, which is TRE in name only, and other things like doing things in haste. So the line we use in the review is build impatiently but incrementally. So don't go so fast that you mess up the implementation.
Great. Linda, hopes and fears.
Okay. So hopes, I think it'll enable collaboration at scale. I think that's a biggie. I hope that it will enable more clinicians to want to get involved in research. I think it'll make it much more simple. Fears, probably pace. I think the pace at which it'll be delivered, and ensuring that interoperability is key, and that we can start to think at really big scales if possible. Yeah.
fantastic. Would there be any questions from the audience? We have about 10 minutes left. No questions? Anyone? Yeah. One brave hand over there.
Hi. Hello, panelists. Thank you. It's a very interesting talk. I have a question about anonymized structured patient data. So there's immense potential and transparency that you've been talking about earlier. Would like to know your thoughts on how do we manage that type of data, or do we need to manage that type of data at all?
Sorry, do you mind if I ask a follow-up? What do you mean in terms of managed? So the kind of legalities around it, or is it?
In any sense, really. It's like how do we, is it by law? Is it infrastructure limited, or is it regulation limited? Is it ethics?
Great, Jess, go for it.
I mean, platforms, you can't. There's been a big myth for a really long time that you can somehow anonymize or pseudonymize patient data, i.e. you take the name and the address off and therefore it's safe to use. And that's just a myth. It's just fundamentally not true. Electronic health records are way too detailed and too dense in order to deal with it in that way. The example that we often give is if you know a person who has given birth, if you know roughly when they gave birth and roughly where, and if they've had multiple children, what ages their children are, that's normally enough information to re-identify someone from a so-called pseudonymized electronic health record. So the only way of really dealing with that data is to not rely on anonymizing the data itself, is to build platforms around it so that nobody is interacting with the raw data. Then, yes, you have to build a service around that, because privacy is not the only thing that matters. Purpose also matters. People care a lot about what you do with that data. So you need to have appropriate ethics around that. And then, yes, we need to change the law, but the law is wrong, not because of the way it deals with anonymity, although that is an issue. The law is problematic in this sense because it differentiates, it causes a fundamental split between direct care and research, and actually in most situations those two things are much more blurry than they used to be.
Great. Any other questions? Ooh, there's one at the front.
So thank you for the discussion, really, really useful perspectives. I guess what I'm curious about, because we use the word data, such a universal term, and this place is full of a lot of health tech innovators, and they're helping with data collection and possibly adding to the problem of silos as well, not intentionally adding to the problem. So I guess my question is really whether the panel sees a sort of a hierarchy of needs when we talk about data and we talk about the types of data, because a lot of these innovations and applications are now giving us access to data that perhaps wouldn't have ever been in the definition of data in the NHS a long time ago. So behavioural data, contextual data about the patient, how they're engaging with what. I mean, all of that is valuable. But I'm just not sure, as I hear the discussion, where that kind of sits in your perspective.
Very interesting. Could I, Linda, go to you first and then Dan?
Yeah, I suppose the short answer from me is I think information standards. I think we have to apply standards to the data we're collecting, and I think there's something about a bit of a mandate on suppliers to comply with those standards. I think that the frameworks should be ensuring that standards are complied with. It's not just personal data as well. I mean, we're doing a big piece of work on service data, and again, especially third sector services, so voluntary, community, faith, social enterprises. And we reckoned we had about 600 directories of services across Lancashire and South Cumbria. And that was varying from something big facing the public and something small like an Excel spreadsheet or a little black book that maybe a social prescribing link worker was having. And again, it's trying to get the suppliers to now comply with Open Referral UK and Open Active standards. And it's the same with personal data. I think that DCMS are working on a new health and care information standard. I heard some talk of that last week, I think. I think it's about creating those standards, but then mandating that suppliers comply with them.
Yeah. Dan, it would be great to get your perspective from, obviously, dealing with data and building these platforms.
Yeah, great question. And I think one of the key things is that there's never going to be a perfect answer for data. So this idea of, for instance, a single version of the truth really doesn't exist within data, and it doesn't really exist within any industry, really, because there are multiple points of collection of data, and there's going to be multiple systems that do that. You know, the alternative is that you have one massive national system that every single organization, you know, just uses, but that's obviously too slow. That doesn't work. So it's really about the ability to be able to stitch together those different silos of data at the point of need for those various consumers of the data, and they need to be able to blend that data together in what you might call a data fabric or something that basically allows the consumers to have that in a secure way for the purpose that they need it for. And I think that's the kind of the data platform type technology that is kind of emerging in this space that would, you know, that allows people to get what they need from data.
Great. And one more question, final question. Yes, hi, Dom. Wait, could we get a mic to you? Hello.
Hi there. I was wondering if you have, at the moment it feels like, you know, data subjects are asked how they want their data to be used occasionally, and there's sort of engagement with...
Sorry, Dom, do you mind just putting the mic...
Is that better?
Yeah, thanks.
Yeah. So I was wondering if you have ideas, whether you think it's sort of feasible and desirable to give data subjects much more kind of granular control on how their data is used, either in direct care or for research.
Very good question. Okay, dynamic and granular consent. Jess, do you want to take that first? Go for it.
I can run with it first. Very tricky. I think we fundamentally, from a population health perspective and a management of a national health system, no, I don't think it makes sense to be handing over too much granular consent to individual subjects because of the inherent risk of bias that would create, and the fact that you would then end up with you're at risk of creating a situation where there are very large gaps in the population that we can't see, and then you can't design the healthcare service for them. We already have an opt-out rate of over 5%, and nobody really knows what impact that is going to have. That doesn't mean that I don't believe that individual consent is important. What I think it means is building a much more trusted and transparent environment in which the consent can be more blanket rather than needing to be granular, because we know that there's a consistent approach to the way in which it's handled. The reason why I think we need granular level consent at the moment is because everybody deals with things in wildly different ways, and therefore you saying yes to one thing that you're happy with might mean you're saying yes to something that you're unhappy with. Once you have a consistency, that issue slightly goes away.
Okay. Anyone else want to add quickly? Yep.
Yeah, just to add, I think from a clinical care perspective, I think starting to think about how technology can help us. So one of the things we're exploring is solid pod technology. But then the challenges are that I, as a digitally activated citizen, can, you know, share my data quite willingly if I want to. But it's the people who are digitally excluded, who won't have the device to enable that digital sharing of data, they're the ones who are probably most at risk, most vulnerable, most likely to have health inequalities. They're the very people whose data actually we would like to share better. So just that's I suppose, a clinical perspective on it, really.
Great. Well, thank you very much. Thank you so much to our panelists. If you could all join me in thanking our panelists for today. Great, and I will hand over the mic for the next session. Thank you.